Hello, everyone. Welcome. My name is Sarah Martin. I'm the moderator of the GBV AOR Community of Practice, and we want to welcome you today to this webinar called Adapting for the Shadow Pandemic, Guidance on Remote GBV Services for Phone-Based Case Management and Hotlines. This webinar today is a joint effort by a large number of organizations. It's going to provide to you an overview of the COVID-19 guidance that we've put together on remote GBV services. It's a collaborative effort, and it was developed by a number of different agencies, including the GBV IMS Steering Committee, UNFPA, UNHCR, UNICEF, as well as International Medical Corps, International Rescue Committee, Norwegian Church Aid, Plan International, and Trocare. It was all compiled together by the GBV AOR Help Desk, and they asked us on the Community of Practice to host this webinar series to present the guidance to you, to give everyone an overview of this latest information. So again, this is a collaborative effort, like a lot of the work that we do here in gender-based violence, and you'll be hearing from 3 different people today. So again, I'm the moderator of the Community of Practice, and we'll be telling you a little bit more about the Community of Practice if you'd like to join later on in this webinar. But you'll also be hearing from Micah Williams, who's a GBV specialist at IMC, Alfreda Kormawa from the GBV IMS team representing from UNICEF, and Dr. Fiona Shanahan from Trocare, who also kindly donated the webinar link for this, this series as well. So thank you so much for that. So before we start to answer your questions, this will not be a session where we will be taking questions and answers live today. This is the first part of a 2-part webinar series. This one will be presenting the tool, and it's giving you an overview. You can find the tool here on this link, and we'll also put it into the chat box so that you can look at it if you want while you're listening to the webinar. But we do encourage you in the chat section or in the questions and answer section to please write any questions that you might have, because we're going to gather all of these questions, and then on March the 11th, we are going to have an interactive and participatory session that you can register for, where we'll be breaking people into small groups and bringing in different people from throughout the field, working for different organizations, to talk to you a bit about how they've used these guidance and tools, and also to let you talk about how you're using the guidance and tools, or what you've been trying to do to address gender-based violence during this pandemic, and also to answer your questions. I'm not sure that we all have any solid answers for everything, because this is such a changing and adapting scenario that we're all working in, but it's an opportunity for us all to come together and to talk more about what kind of support we need. What do you need from the GBV AOR? What do you need from the Community of Practice? What can the different organizations and agencies learn from each other? What can we learn from different contexts? Because this is one of the unique humanitarian emergencies where we find ourselves all in the same situation, but with very, very different contexts. So please register on March 11th for the second webinar, where you can bring your questions and be prepared to talk and to ask questions about things that are happening yourself. In the meantime, again, I encourage you to write in the chat box anything that you have, any big things you want to know. And if you want to, even if you'd like to present in March 11th and tell us more about what you're doing. So write in the chat box, and we'll be collecting that, and we'll give you an opportunity then as well. So before we launch into the webinar, again, I wanted to mention that I am the moderator of the GBV AOR Community of Practice. The Community of Practice is open to any gender-based violence and emergencies specialist who's currently working, or is, even if you're on a sabbatical or a break. But we're a virtual online platform where we bring together people who have experience in this, who are learning, sharing. We share new resources. We try to help develop resources, and we support each other. Because as we all know, everyone working in gender-based violence right now, that it can be a very difficult and stressful job. And so a very important part about that is to bring together other people who are also doing the same work as we are. And we aim from around the world to support each other and to help each other do the best job that we can for gender-based violence survivors. We have almost 900 members at this point, and we're represented in all the different continents except for Antarctica. But we also encourage you to communicate in French and Spanish, but we're predominantly in English. At this point, we don't have the resources to translate into Arabic, but hopefully in the future we will do that. So I'm sorry, Arabic-speaking colleagues. I know it can be a challenge for you all. But please, if you're interested in joining the community of practice, stay put till the end of this webinar. And this webinar should go for 60 minutes. Stay put to the end of the webinar and we'll tell you more about how you can join. Plus, my colleagues will be putting things into the chat box to help you find your way around for those of you who might be new to the gender-based violence area of responsibility. So we'll be sharing information on our website, how you can join the COP, the help desk, where you can find the tools, and this Dropbox of COVID tools that we have developed for you as well. Okay, without any further ado, I will now turn it over to Micah Williams.
Hi, everyone. Well, thanks for joining today. It's great to see so many participants. I just wanted to start with an overview of the guidance that we're talking about today and take you through the first few chapters, just so everyone's clear about what to expect. We can move to the next slide. Thank you. So Sarah mentioned that the guidance was developed by a lot of different organizations, and some of you on the call may have seen pieces of this over the last year because we've been working on it through our different agencies. A lot of the content was developed based on internal or existing interagency guidance, just to further flesh out some specific guidance that's particular to the COVID-19 context. But it was developed pretty quickly at the global level by some of us on the call today and many others. And I want to stress that point because it isn't something that has been field tested and developed through, a really participatory process across multiple contexts. It's more developed through our existing guidance and trying to adapt for the current context. And though that process is not usually ideal, we worked this way because we were trying to relieve the heavy workload of field-based colleagues and try to do as much as we could at the headquarters level to kind of put this guidance in one place. So we recognize at this point that there's still a lot of learning and that this probably would need to be tweaked in the future as we learn more about how things have gone related to remote services during COVID. And I think all of us are really looking forward to the discussion on the 11th to hear some inputs from different teams. But essentially, our purpose with this guidance was to try to look at what was required in order to keep GBV response services open and available throughout different stages of the COVID pandemic, while also ensuring that staff and survivors are as safe as possible. And that means not only an appreciation for the fact that staff and supervisors, they're all working in a context themselves where we know GBV risks are increased, but also being really conscious of the risks of transmission with COVID and what that means for in-person services and sometimes even phone-based services. So I mentioned that the guidance is complementary to other resources, particularly the guidance that came out last year. There were different versions of it. The final version was released in May 2020 from the GBV-IMS technical team and steering committee. And that was a more brief guidance paper on providing case management services during COVID. And that document identified 3 models of service delivery. The first is in-person GBV case management services. And the second is phone-based case management services. The third then is GBV hotline services or open access hotline services. And that guidance note also talks about some basic things that are required to deliver those three services at different stages of risk during the COVID pandemic, or different stages, I guess, of shutdown, as it were. So just to clarify then, this guidance is looking specifically at the two remote services. So this guidance doesn't include additional information on how to make in-person services safer. We have that already through the one that I identified. We also have that through a separate guidance note that we developed and released in April last year on women and girls safe spaces. So that talks about how to keep women and girls safe spaces open through different stages of the pandemic and safe, including hosted case management services within. So if you haven't seen or found those resources before, they're all available through the COP resource site, and I'm sure Sarah will share the link. But I want to talk a little bit more today about the overview of what we're talking about when we talk about phone-based GBV case management services and GBV hotline services. So the next page. So I don't know if anyone on the call is surprised now to hear these two services talked about in separate terms. We found early in the pandemic that people were often kind of abbreviating this idea of remote services and sometimes talking interchangeably about remote case management and hotlines. And in the field, we found that to be pretty problematic because they really are two very different types of services that we could offer remotely. And so one of the first things we wanted to do with this guidance, we saw a real need, even amongst ourselves, to kind of unpack these terms and find some common definitions across all of our agencies for consistent use in the field. So briefly, phone-based GBV case management is still GBV case management services. So that service should look like the services we expect to see as they're defined in the interagency GBV case management guidelines. It relates to an ongoing relationship between a caseworker and a client. And for the most part, this phone-based remote service relates to shifting an existing service with existing clients into something that's phone-based. So each caseworker who already has open cases, when those survivors are no longer able to safely access in-person services, they might shift to phone-based services. For some service providers, there may also be a possibility to extend the phone-based case management service to new clients. And that would probably only be through direct referral. So this isn't a service that would be advertised on billboards with a phone number for kind of open access calls. GBV hotlines, on the other hand, are just that. This is an open access phone number, maybe multiple phone numbers. It should be open to the general public. Sometimes it's for extended hours or even 24 hours. And that is not a case management service. It should be considered a line for crisis support, for psychological first aid. And importantly, we hope that GBV hotlines also serve as an entry point and a point of referral to other GBV response services, including case management services. I'm not sure where we are now in the presentation. We lost our way, right? Okay, so I hope that's clear. There's, of course, more in the guidance on differentiating between these two services, but if we can shift to the next slide. Overall, the guidance that we're talking about today, this is a snapshot of the table of contents. So this is the broad contents. In the introduction, we outline some specific guiding principles and key considerations for either remote service. And then chapters 2 and 3 get into detail about what's really required, some step-by-step guidance for establishing and delivering those two distinct services. And then chapter 4, 5, 6, and 7 have some common elements that would relate to both remote services, although each chapter does include some key considerations, perhaps for Hotline. I see a question popping up that I just want to address quickly. We use the term hotline in this guidance, but some people might also refer to that as a helpline. So we didn't differentiate between those two terms. But we also found again that these terms are being confused in the field, and sometimes people talked about a helpline when what they really mean is remote GBV case management services. And I think bringing some clarity definitely for the populations we serve, but also for donors and partners is really important. So the last chapter of the guidance includes some key resources to additional information, and that's additional information related to COVID, but also more general guidance that this is rooted in, like IRC's remote and mobile services, the GBV minimum standards, etc. So next page. So in the introduction, I mentioned that some key considerations are outlined. Just to highlight a couple of really critical points, for any teams considering establishing either remote service, there are some important questions to ask around what's really available, what's possible, related just to technology. And that's not just whether there's electricity and phone lines, but really importantly, what is available to women and girls. What is safe for them to access in their homes? Do they individually have phone credit or telephones, etc.? So answering these questions will definitely require some conversations within your team and partners and community, but it really requires consultations with women and girls in the community as well. Then for safety and privacy, that relates to both staff and survivors, of course. And there's also information related to safety and privacy. So if survivors are calling from shared phones, what does that look like in the COVID context? So if we can move to the next page, I want to dig in a little bit into some of the chapters. So the first chapter covers establishing and delivering phone-based GBV case management services. And here you can see an outline of what that chapter includes, from prerequisites, looking at what staffing is available, and whether your program is really equipped with what it needs to adapt services at this time. And then a lot of information under operationalizing remote case management services. It's not an easy shift, and credit to all of the teams around the world who made this shift quite quickly in the last year, but there is a lot that goes into it, starting with just layers and layers of consultation. In order to even look at the opportunity to shift to remote casework, of course, it needs input first from our own teams to make sure that's feasible and safe for caseworkers themselves, especially if they're working from home, for supervisors, how they continue to connect, etc. And then you need to consult with, not at this level, not the specific clients, but talking with women and girls generally in the community, and also talking with referral pathway partners. And then the communication, again, goes to, if you're going to operationalize the remote service, then talking individually with each client about shifting that service, talking with the community, what does the service look like from the community perspective, what do they know about it, and again, talking with partners to make sure, especially that referrals can be adapted in remote service provision. And then the next part of this module is developing standard operating procedures, or SOPs. So that includes many elements, but one of the important considerations that we got a lot of input from teams on was call answering protocols. So how does that, what does the initial call look like? Who makes the call? Are callbacks possible? Because we usually defer to survivors initiating the call. In some contexts, we found practice where they developed safe systems in consultation with women and girls at large, and then in consultation with individual survivors where callbacks could be possible under certain circumstances, maybe like a dropped call or a text, something like that, so that no cost was incurred to survivors. In other contexts, people found that it simply couldn't be safe. So there's some guidance there talking about the different considerations and also sharing some examples from different locations. The SOPs need to, again, include the referrals. There's a bit more information on that in a separate chapter. And then the administrative procedures, so supervision and monitoring, et cetera, looking at the service. I'm going to go to the next page. So more sections of that first module. We have a section on including training caseworkers. So this doesn't take you through everything a caseworker needs to learn to be a caseworker. We would defer to the interagency case management guidelines for that. But at a minimum, we would expect caseworkers shifting to remote services to be oriented to those standard operating procedures once they're established in your context. And that should involve some role play where they can kind of practice those calls, because of course, even for really experienced caseworkers, this is a completely different way to deliver services. And then in addition to that, some refresher training would be great. There's some guidance on if that training needs to be provided electronically over something like Zoom, what that should look like. And then we get into the service itself, working with clients. So some information on shifting clients to the remote service. That's of course only with each individual client's agreement. And the idea is to proceed as much as possible with little disruption to the case management service where rapport is already established with an individual caseworker, but then information on how to update a safety plan, assessing new and evolving risks with existing clients, and different ways to check in than what they might be used to. There's also information on plans for working with any new clients. This wouldn't be required. Some services might shift to remote services and not accept new clients. There's information on what considerations each team would need to make as to whether or not they could take new clients, but that would again only be through referral. But for new clients, the case management service is going to be an abbreviated service, similar to crisis case management, and clients will probably move more quickly through those initial steps of case management. The final section of Module 1 is some information on how to manage the calls themselves. So you see some steps here that start to mirror the steps of a case management process. This is related just to a single call with a survivor, between a caseworker and a survivor. So within introduction and engagement, there's information on how to start that call. How do we ensure that the client feels safe? Some questions that a caseworker might ask just to quickly inquire if it's good to proceed. And some practice from teams. Some places they might have like a verbal password or something to make sure that it's safe to have that conversation at this time. And then the second step is to continue to assess needs with the client, even for very familiar clients, understanding that the COVID context might increase or present new risks. And then planning with the client, that includes the updated safety plans, adapting safety plans to respond to those risks, looking maybe at safe zones within the house or escape plans if needed. The implementation, that's going to be the implementation, of course, during the call itself, some of the direct psychosocial support, the checking in, but also possibly referrals for additional services. And there's some guidance on how caseworkers need to get the verbal consent over phone-based case management, which might be different to their usual procedures. The final step then is how to wrap up the call, and ending with provision of some resources, some key messages, plans for following up next time, and trying to end in a supportive manner. So that's a snapshot of the remote phone-based case management services. Module 2 then goes into establishing and delivering GBV hotline services. So here I want to stress again what we went over a few slides back, which is this is different from remote GBV case management services. And I've included some text directly from the guidance here from pages 22 and 23. I think it's really important and a good summary of what a hotline is and what a hotline is not. Again, just emphasizing this is for psychological first aid, for crisis support, possibly for safety planning, a really important service, possibly for referrals to in-person or other remote services, also a really important service. But very likely hotlines are not providing ongoing support. It doesn't establish a relationship between a service provider and a client. Even though clients may call multiple times, they might not always receive the same person on the other end. And a final point that, given this limited scope, hotline services were never designed to replace GBV case management services. And I know that that's been sort of loosely suggested in some of the early pieces and advocacy notes that might have come out during the COVID pandemic. And I think that's a really important thing that this guidance clarifies. So next slide. So within the module 2, you'll see that the outline for module 2 starts to mirror the outline for module 1 with some differences, of course. The first is, again, the prerequisites, looking specifically into some detail about what is required for human resources in a hotline. There's no easy one answer there. It depends a lot on the size of a hotline, the density of the population, whether or not you have GBV staffed, people who are already trained in GBV available to provide a hotline service, or whether you kind of need to start a service from the ground up will make a big difference. If you need to provide a hotline serving multiple languages, that's going to have critical implications for the staffing. And then the other prerequisite is looking at the referral pathway and information resources. So this is important because beyond what we would expect with remote GBV case management services, a hotline might be serving broader populations. So they might actually need to tap into multiple referral pathways. If this is, say, a national hotline, then that's going to relate to, if you want to direct people to in-person services, you need to have an idea of services in different locations. It could also be that you need some information on even other services, because people will find their way to a hotline when really maybe they're seeking a different kind of support. And maybe you want to at least be able to direct people to other sources of information on COVID-19. So then again, there are steps to operationalizing a hotline versus the case management services. And here we have some specific sections in operationalizing. Again, it requires that we look at what's available. So looking at the phone devices, how those are managed, what are the hours of operation that relates to human resources, but also just the administration of the hotline. Getting into the SOPs, we establish these for the case management services, but there are again some differences. So the guidance goes into specific elements that should be part of your hotline SOPs. That includes the call answering protocols. And in the guidance, we have some scripts that we'll get into a little bit, running out of time. Again, whether you have callbacks, The hotline service provider will need probably some general information at their fingertips. So there are some recommendations around tip sheets that they could have that could be related just to supporting survivors, common reactions to GBV, but also information related to specific legal statutes and processes, mandatory reporting procedures, and basic information on COVID, perhaps other information. So I want to move to the next slide and get into a little bit about actually delivering the service, which involves training the hotline staff. So here, if we're starting from the position of staff not having a background in GBV, there's an outline of the information, of course, that they would need related to GBV response, understanding hotlines as an entry point to other services within the multi-sectoral system, but also, of course, delivering on the hotline service itself. And then there is a lot of guidance on responding to calls, much of this drawn from existing information from some of the contributing organizations. So that, that section goes into detail on what answering calls looks like. It develops or it outlines specific steps that a hotline staff would follow, provides some sample scripts that could be used and adapted, also information on how to close calls, and then responsibilities for the staff to take after a call is ended. I'm not going through in detail that information here. I just want to make sure everyone knows that it's contained in this guidance and where to find it. There is also guidance in the hotline section on managing particularly challenging calls that would be more likely, especially to come through a hotline. An open access hotline might bring forward all sorts of troubling calls, some that might not related to GBV that are seeking other types of support. But there are also going to be calls that might be angry or disruptive, perhaps even calls from perpetrators, long calls, silent calls. So there is good detailed information about the different types of challenges that might emerge to help prepare the hotline staff. So then, Module 3 includes more information on some of those challenging calls, but this module relates to both GBV case management services and hotline services, because within this module, there's information on safety planning, more detailed information on safety planning, which could be provided through remote case management services, but abbreviated safety plan service could also be provided through a hotline staff provider. It certainly does happen. And then there's also information on supporting other high-risk survivors. So survivors who might be in immediate need of security help, also survivors who express suicidal ideation, or who a caseworker or hotline staff might be concerned is suicidal. So that includes some information on going through a suicidality assessment and then supporting clients who demonstrate that risk. And then within that, there's some additional considerations specifically for hotline support, because that's of course different from the ongoing relationship you might have with a known client. I should have mentioned at the beginning, maybe it's obvious, but one of the key differences, of course, is that with a hotline, it's both a benefit and sometimes a drawback that the survivor is anonymous. So the hotline staff wouldn't know how to get back in touch with the survivor through a hotline and doesn't have that ongoing relationship. And then back to the safety planning, there are also the key considerations for hotline support within that. And of course, information on the basic elements of safety planning, but adapting that for the COVID context. So my final slide, I think. And then module 4 relates to both services as well. this module is pretty brief. It goes through the importance of updating referral pathways for remote services. So it includes considerations for updating pathways during COVID, with all of the known complications, including other service providers perhaps working remotely, or other services no longer being available and really needing to stay on top of what's still possible. And it also includes recommendations for sharing referral pathways with communities and with partners during the COVID response. So I think that's it for my slides. Thank you very much. I hope it was mostly clear.
Thank you so much, Micah. And next up is Alfreda Kormawa from UNICEF and the GBV IMS team. And I did misspell her name on the slide, so I apologize for that. Alfreda, over to you.
Thanks so much, and not a problem. So I'll be speaking on Module 5, Documentation and Data Storage. Next slide, please. And this section of the guidance notes really acknowledges that collecting personal and sensitive information from survivors is a huge part of what GBV staff do when they are providing services at the field level. So we know that survivor data like demographic data, like name or age or the community that they come from is collected. Maybe we'll collect details on the type of violence. And of course, we also document information related to the data management, to the case management process. But recognizing that in the context of COVID-19, a lot of caseworkers are actually working from home. There's a changing landscape of where services are being delivered from. There are a number of considerations that need to be taken by both caseworkers and supervisors to ensure that the documentation of this data is safe, it's ethical, and it does not cause more harm, and ensure that there is the client data is protected at all times. Next, please. So the first part of this guidance goes into some key considerations that you need to take related to documentation and data storage for phone-based case management. There is a recommendation from the global level that paper files are not used, or hard copies, sorry, of GBV case files and any other identifying information are not stored in a caseworker or a supervisor's home. So we're speaking about things like the consent form, the intake form, any of the case management forms, because really of the possibility that there could be a breach of confidentiality as well as data loss. So there are a number of recommendations that are provided in the guidance around, maybe, or not maybe, but definitely asking your caseworkers to obtain consent verbally. Caseworkers should avoid taking written notes at all points. If a caseworker has to collect or record the number of their client, of the survivor, that they use anonymized codes to do this, and that this maybe be linked to a separate password protected file on the caseworker's laptops that connects them to the phone. And also just a recommendation that organizations that typically do rely heavily on paper files, considering to shift to using new technologies that support safe and confidential collection of data during remote service delivery. So we put a plug in there for the GBV IMS Plus module, which is one of the latest applications that allows for the humanitarian workers to safely collect, store, manage, and share data for GBV case management and incident monitoring. Next, please. Key considerations that you should take if providing hotline service is also outlined in this particular section. So it reminds us that because hotlines operate as crisis support, and it's not necessarily your fully fledged GBV case management service delivery, that the only data that should be collected is to track general information about the uptake of services. And so for hotline providers, that includes anonymized call details, such as what is the date and the time of the call, what is the length of the call, the types of incidents that are being reported, or indeed why it is that the survivor has called and asked for assistance, and any other types of referrals offered. Next, please. The recommendation, as has already been said, is that for hotline providers, no identifying information about the caller should be collected, but we recognize that this might not be realistic or feasible at the field level. And so if information has to be collected, normally because of referrals, then hotline providers are, or operators, I should say, are recommended to destroy this information at the end of the call or as soon as the referral is made. There's also some language in this around maybe providing operators a lockbox, so agencies providing operators a lockable lockbox. If they are not able to destroy this information, and they can keep that content in there. Of course, the only exception that hotline operators would be in where they can collect data would be in contexts where they are using the GBV IMS or the GBV IMS Plus. And if that's being, if hotlines are being rolled out in context where the GBV IMS Plus is already being used, then there's an opportunity there to discuss reducing the number of data fields in the GBV IMS Plus to contextualize it for hotline use. Next, please. The section also provides a little bit of guidance on information sharing within the context of supervision. Naturally, because services are going to be provided remotely, there's going to need to be an adjustment in how it is that information sharing between supervisors and supervisees is conducted. So there's recommendations and language there for the need to have training to basically be clear about what type of information is shared when you're discussing information about clients, either on the phone or in messages. And supervisors really must take the lead in reinforcing this practice whenever speaking to supervisees. And we recognize that during this period of time, there are lots of peer support spaces that have been created. So for example, WhatsApp groups or group calls, and whatever safety and confidentiality protocols that have been created at this time must also be extended into those spaces. So no use of identifying information in your WhatsApp group chat. For those organizations or contexts where the GBV IMS Plus or another digital GBV case management tool is being used, there's also contained within the guidance some suggestions on how it is that the GBV IMS Plus, for example, could be used to facilitate remote supervision, maybe through the review of case files from once to twice a week, depending on what you want to do in your organization, through using different functionalities of this digital tool to basically share back to the caseworkers any trends that have been noted in the case file reviews, as well as using the functionalities as well, like the flagging function and the approvals function. Next, please. So the Primera GBV IMS Plus is actually introduced near the end of this chapter in the guidance note. And for those of you that know or don't know, the GBV IMS Plus is a survivor-centered module within Primero that uses technology enhancements to accompany the full GBV case management process, manage individual cases and referrals, as well as support things for aggregate incident monitoring. So there are a few assessments that would need to be conducted before rolling out the GBV IMS Plus, specifically aimed at looking at the quality of your existing case management service, and these are normally conducted at the interagency level, at the field level, as well as at the global level, where we have different tools to facilitate that process. So the guidance goes into that a little bit more. Next, please. And then on page 59, the guidance really speaks to what features and functionalities of the GBV IMS Plus lend itself to GBV case management service provision during the COVID-19 pandemic. And sort of lists them out. So of course, first and foremost, it's a digital tool, and so it allows caseworkers to go paperless, and that obviously provides a solution to paper file storage issues that GBV caseworkers may face when working from home. It touches on the fact that the tool can be used in low or infrequent internet connectivity contexts. Not only is there a web-based version that offers the full or highest level functionality, but also an offline data entry that you can conduct using Primero Mobile. And there are different sort of, or should I say, additional solutions that can be installed on the mobiles, like a mobile device management solution, to ensure that the safety and confidentiality of data is maintained. It speaks to the fact that the GBV IMS Plus facilitates supervision, recognizing that, of course, supervisors are confined to their homes as well as caseworkers, and there might be limited person-to-person interaction, again, through the use of features that I mentioned before, the approvals feature, the flagging feature, where you can add flags or ask your caseworkers to sort of get, request for an approval on an action plan or a case closure. Yeah. And then it also speaks to the fact that the GBV IMS Plus, the data on the GBV IMS Plus is hosted on an internet cloud. And so, especially in contexts where there is ongoing interagency sharing of GBV IMS Plus data, this can continue because it means that organization focal points only with a click of a button can export GBV IMS data, paste that into the GBV IMS incident recorder, and share that with their interagency GBV IMS focal point and country, and continue to share aggregate anonymized statistics. And finally, it speaks to the fact that the GBV IMS Plus actually features heightened security, and it's built on a secure framework that was field tested before, obviously, we launched the tool. So definitely look at that part of the guidance if you want to find out a little bit more about the GBV IMS Plus. Next, please. And then this particular, and then it ends with acknowledging that there are contexts where the GBV IMS Plus maybe has already been rolled out amongst a small number of partners within that specific context. And so, it's quite easy to adapt it to remote case management. All you need is a access to the internet, a way of entering data privately, access to supervisors in order to troubleshoot any issues that arise. And if there are service providers that are providing hotline services that wish to use the GBV IMS Plus, this just requires that a conversation be had with the interagency focal point and country, an agreement be made around the sort of data fields that would be required for using it in your hotline service. And of course, the provision of training and things like that as well. So that's really what this section of the guidance is all about in 10 minutes.
Thank you so much. Very well done. And finally, we're going to move over to Module 6 now with Dr. Fiona Shanahan from Trocare.
Thank you very much, and great to see so many people on the call. And I'm going to be focusing on support and supervision and staff care, particularly for caseworkers and hotline staff delivering these remote services. So if we could move to the next slide. Great. So first of all, just in terms of an overall framing of staff care and why it's so central to GBV service provision, organisations have a duty of care towards all of their staff and volunteers and specific responsibilities around ensuring their safety and well-being. But we know that certain subsets of that broader population face greater exposure to stress and potentially traumatic events. And GBV service staff would be one of these subsets of that population because of the types of stresses and the types of material that you're dealing with through GBV response work. Additional kind of elements or characteristics that can lead to greater exposure of stress within that group are existing experiences of stress or discrimination or limited access to resources. And so when we're talking about staff here, also just to note that we're talking very broadly about staff, volunteers, incentive workers, anybody who's working in our GBV response services, and really kind of taking into account the different vulnerabilities that they might be experiencing. And specific attention, resources and support should be allocated to support those individuals. Additionally, GBV service provision itself, so providing remote services, is really situated in the relationship between the survivor and the service provider. And that's true of an ongoing relationship, but also of a moment-to-moment or kind of specific relationship that you might have in the moment of answering a helpline call, for example. And the quality of that relationship is really critical for outcomes. And we know that different types of stress impact on the quality of that relationship and therefore on outcomes, in addition to negatively impacting staff themselves. If you'd like to learn more about the different types of stress, a previous webinar that we did on staff care goes into this in more detail. But very briefly, stress would be kind of everyday challenges. Cumulative stress is when these accumulate or build up over time. Critical incident stress relates to a particular event or a potentially traumatic event. Compassion fatigue is the experience of a lessening of your feelings of empathy or support towards people seeking help as a result of ongoing stress. And burnout is an experience of emotional, physical or mental exhaustion as a result of ongoing or excessive stress over a period of time. So thank you. If we could move to the next slide. And I just wanted to zoom in on this for just a moment to show you a representation of what this can look like in practice, particularly around compassion fatigue and burnout. So the center of this kind of diagram here is an ideal area of coping and responding to people in distress while being mindful of your own well-being and your own limits. So you see that there's things like empathy there that can be a movement towards others, but also a setting and maintaining of boundaries and registering professional distance. What we see at the more kind of extreme ends of the diagram, so over towards the right and over towards the left, are really indications of how compassion fatigue and burnout can show up for people. And this often looks different for different people, but can be this movement away or a movement towards. And I think if you look at the under-involvement around the movement away, so kind of feeling detached or numb or cynical or a lack of empathy, that's often kind of recognized maybe more quickly as burnout, whereas the movement towards things like, you know, a savior attitude, finding it very hard to delegate, having this exaggerated responsibility for people's feelings and problems, that over-involvement sometimes takes a little bit longer for people to recognize as burnout or as compassion fatigue. And this is often kind of a type of indication or a pattern of indication that you can see in GBV response staff and service providers, and kind of aligns with that role in many situations. So this is really just to bring some of this into our awareness and give us a sense of what it's important to think about when putting good, strong systems in place for staff care and support. And if we could move to the next slide. So first of all, just to kind of dive into support and supervision, and this is on page 61 of the guidance. So really just first articulating what it is. So ongoing regular supportive meetings between caseworkers and hotline staff members, who are the supervisees, with more experienced GBV specialist practitioner, so their supervisor. And the purpose of these meetings is to support their practice, skills, and well-being. So these are regular support sessions. They involve discussing maybe particular cases and types of support that the caseworkers and hotline staff are providing, but also how that's impacted them personally, any kind of psychosocial aspects of the work, and also how their kind of own experiences or things that are being triggered for them might be impacting the work. So it's different to line management supervision and is very much a psychosocial space that looks more at developing skills in practice and psychosocial well-being. So the recommended limit of the ratio of supervisors to caseworkers or hotline staff or any response staff is 1 to 5. So for one supervisor, you should have a maximum of 5 response staff. And in emergencies, the minimum standard is 1 to 8, but you should try and reduce that to 1 to 5, which is the safe level, as quickly as possible. And the level of supervision will increase if staff are less experienced, and also in situations of remote case management or acute emergencies. Ideally, you would want the supervisor to remain the same person if you can. So when shifting to remote services, if the same supervisor can continue to support their supervisees, that's preferred. And if we could move to the next slide. Great. So on page 62 and 63, it goes through how to adapt supervision practice. And I'm just going to touch on a couple of the key points here. Very practically in terms of preparing, just making sure that all supervisors and caseworkers or hotline staff have an agency phone so that they're not using their own personal mobiles, and that they have communication allowances like top up or airtime. Making sure that if you're using specific technologies or just things like WhatsApp, Skype, Zoom, that those are downloaded onto people's phones in advance, so they're not using data for that, and that people know how to use them, and that there's kind of, that people have a bit of support around how those are going to be used. And then in terms of practice, so just making sure that there's very regular supportive communication between supervisors and GBV caseworkers or hotline workers, having daily either group-based or individual check-ins and check-outs with team members who are offering phone-based case management and crisis support, and then also having standing weekly or possibly more frequent individual supervision calls, so between a supervisor and each individual supervisee. And really talking to your team and thinking through what are the most appropriate tools to allow for ongoing capacity building as well. And monitoring and supporting the well-being of staff, and for supervisors themselves to model healthy work practices, boundaries, and self-care. And a really critical thing as well is to make sure that there is a pathway of supervision so that the supervisors themselves have access to supervision. And so that kind of link with more specialized GBV program staff or other GBV specialists is there for supervisors as well. If we could move for the next. So to move on to staff care, so there's a number of things in the guidance beyond supervision around kind of staff care practices and how to put those in place. And I think a really important element is making sure that not all staff care practices rest with the supervisor, and ensuring that there's a very clear organizational responsibility and organizational practices around staff care. To prepare for staff care elements when shifting to remote either case management or helplines, there are some key questions around the real kind of practicalities of how staff are going to do this from home. Really asking and having open conversations about how comfortable people feel providing these services over the phone and from their homes. Asking questions and talking through aspects of the living situation or any caring responsibilities that might impact that. Really, taking seriously the needs in terms of flexible working or reduced working hours to facilitate care. Thinking about what confidential spaces might be available to homes or whether they're available for caseworkers and psychosocial staff to provide services, and thinking about where they might not be interrupted or would be able to have a private space to work. Thinking about other policies, and Micah and Elfrida have mentioned some of these around policies in relation to callbacks, for example, or other policies related to making and receiving calls, and how those might impact staff from a staff care perspective. And also putting in place and thinking through with your team resources to support their well-being, including any social check-in activities or other things that you might want to put in place. And very practically in terms of the practice elements then, once you've done that preparation, is thinking through workload and working hours. So making sure that you don't exceed the safe limit of 16 contact hours per week, as included in the interagency minimum standards. Making sure that you've included time for breaks, meals, administrative work, wrap-up time and handover in shifts. Ensuring adequate staffing and shift coverage, and making sure that you don't have any lone working, so that staff are not the only one on duty at any time. Making sure that you have at least 2 staff members on duty at any one time. A really key aspect is caseload. So a maximum of 20 active cases per caseworker, and then 15 cases really is a safer limit, and seeing how to manage that in terms of the total caseload that you have and how that's balanced across staff. But aside from those numbers, which can be used as a rule of thumb, complexity of cases also matters. So if you have a caseworker who's managing or responding to supporting a number of participants with particularly complex needs, then rebalancing that caseload across the other caseworkers in the team would probably make sense. And so kind of keeping those conversations live and ensuring that people know how to seek support, and also that support is offered without them having to seek it. Ensuring as well that caseworkers know that they have the right to withdraw if there's a particular client that they don't feel comfortable with, in terms of it might be safety issues, it might be issues related to their sense of competency. And so the right to withdraw and making sure that there's no repercussions to that is really important, and that's detailed within the guidance as well. Promoting work-life balance and self-care is critical, and ensuring that any additional psychosocial support that is offered to staff is evidence-based and has clear boundaries, and is voluntary as well. So if we can move to the next slide. Very briefly now, in addition to those elements, there were also other considerations for hotlines. The kind of intensity of hotline or helpline work is different to offering support to ongoing clients. And so limiting shifts to 4 hours maximum is recommended, with no staff member completing more than 1 shift in 24 hours. And so this kind of key element will impact how you plan your service in terms of the roster and kind of weekly hours that can be covered by the team. If case managers with a current caseload are shifted to hotline services, there really needs to be quite careful consideration, thinking through how many hours in total are reasonable and how many clients in terms of their caseload is reasonable to make sure that that's appropriate given the kind of unusual stressors associated with switching to remote services and also the ongoing situation. And also for hotlines, it can be helpful in addition to the other supervision mechanisms to have a buddy system. So where each staff member starts their shift with a handover with the person who's finishing the previous shift. And this can particularly be helpful if you're starting into a shift to be aware of any kind of ongoing actions related to the helpline, particularly challenging calls that have been happening that allow people to prepare and as they get started into their work. And it's also an opportunity to check on the well-being of the staff member who's finishing the shift. So if we could move to the next slide. So just to finish with, I'm just going to share a couple of additional resources. This one is related to staff care and we can share it in the materials from the webinar. But one of the things that we found really helpful when having conversations with teams and managers was this summary of evidence of what works and what doesn't work in the acute phase of emergencies around supporting staff care. And so this summary was developed by the King's Fund, and in particular, some of the advice, you know, it's nothing new, but some of the advice around single session psychological debriefing, or, you know, making sure that we don't rush to provide psychological interventions when that might not be the most helpful thing for people was really important for us. And so, you know, this really does reaffirm the emphasis on supervision and appropriate staff support and supervision, rather than jumping to additional psychological interventions or practices that may not have as strong an evidence base or may not be helpful to people, particularly in the acute phase of an emergency. And the other resources I wanted to share, if we could move to the next slide, are around self-care resources that were provided by the GBV AOR Community of Practice. And those are available on the YouTube channel that Philippe has been sharing in the chat. But I've also included the link here specifically for that playlist of self-care practices. And there are practices there, short videos in English, French, and Spanish that guide you and walk you through self-care practices. The webinar that was done specifically on staff care is also really useful and is available. And then other tools that people might find helpful themselves would be the self-care inventory, which is also shared as part of the Interagency GBV case management guidelines, self-compassion exercises, and also skills building resources that incorporate staff care, like the responses as guides for action, which we'll include as part of this, ROSA, which is the remote online skills building application developed by IRC, and also the Inspire guide, which has a strong focus on staff care. That's a Troca resource that's forthcoming. So a range of resources there that might be of interest to people, and happy to take these conversations forward. Thank you.
Thanks so much, Fiona. So that brings us to the end of this webinar. It will be recorded, so you will be able to access it, and we will send you all the PowerPoints, not just a PDF, but the PowerPoints, so that you can actually adapt them if you need to, use the links. And we've been sharing in the chat the different ways you can download and access the different materials. So I just want to put a plug out right now at the end for the GBV AOR. For those of you who are not familiar with us, we're the Global Gender-Based Violence Working Group. And you can go to our website and get more information, all of the materials your heart could ever hope for on gender-based violence. I am Sarah Martin from the Community of Practice, and if you're interested in joining us, you can join over 800 gender-based violence specialists in a virtual platform to support each other, share resources, and try to find better ways to support the survivors that we're here for. And you can send me an email at gbvcop@gmail.com. And finally, for the help desk, who helped pull together this resource for everybody, I wanted to just tell you a little bit more about it. So the help desk is a research and technical advice service for individuals or organizations working to prevent and respond to GBV. So they produce knowledge products like some of the ones that you heard mentioned today, but also they provide free and confidential tailored support to you, the individual, or to organizations who are trying to do frontline gender-based violence programming in emergencies. We cover a number of different topics, and you can write directly to us at inquiries@gbviehelpdesk.org.uk, including finding more on guiding principles, healthcare, case management, mental health, access to justice and legal aid, et cetera, et cetera. If you submit your requests, you will receive a response within 24 hours during the weekdays. So please send any messages that you might have to get more guidance and support to the email address right here at the bottom. So finally, I hope to see you all and then hear from you as well on March the 11th. The webinar will start 1 hour earlier than it did today. It will go for 90 minutes and it will be a facilitated discussion. So we're contacting different people in the field who are using these tools. We've been collecting the questions you've been asking in the chats and in the Q&A today, and we're going to structure it with breakout rooms and groups so that you'll be able to talk and ask questions and try to, connect with people in other sections in other countries that are facing a lot of the same problems that you are. So I hope you'll take the time to register. The link is here, and I hope Philippe is putting it back in the chat room again, but we'll see you on March 11th. And again, if you want to follow up this conversation on the Community of Practice, please feel free to join us. Thank you to the fabulous panelists. Thank you to the GBV AOR staff who supported the webinar here. And thank you to all of you guys who stayed and listened and are doing all the hard work in the field. We appreciate you. Thanks so much, and goodbye.